Today we are going to discuss about neonatal convulsion. In my previous video, I have discussed treatment of convulsion in a age group more than 3 months. Please be remember, if any patient having convulsion in less than 3 months, the treatment protocol for that convulsion is just like similar to neonatal convulsion treatment protocol. That means less than 3 months, if a patient having convulsion, we have to treat the patient just like a protocol of neonatal conversion treatment protocol. Why? Because in less than 3 months, the GABAergic receptors are much more less than the adult GABAergic receptors. That's why there is a decreased effect of benzodiazepine. So benzodiazepine is not act promptly in age children less than 3 months of age. But after 3 months, the GABAergic receptor are much more and they having some inhibitory effect. So that's why more than 3 months we are dealing with conversion with midazolam or lorazepam or any other benzodiazepines. So please be remember, if any patient having conversion less than 3 months, we have to treat the patient as per neonatal conversion treatment protocol. Now continue the neonatal conversion. What is neonatal conversion? The definition of neonatal conversion is it is a transient occurrence of sign or symptoms resulting from abnormal, excessive, or asynchronous neurological activity in the brain. That means in the brain, if there is a asynchronous or excessive neurological activity occurs, then there is some signs and symptoms present in the neonates which causing neonatal conversion. Now, why the neonatal seizure are much more common than the children? As because the brain are immature in neonates, and the immature brain of a neonates are much more excitable than the adult. That means the mature brain are much more inhibitory, having inhibitory effect, and the immature neonatal brain having much more excitable effect. That's why they are vulnerable to seizure activity. Along with this, there is a delay in the sodium potassium ATP mutation, and there is a delay in increased NMDA and AMPA receptor density. That means the neonatal period, the receptor like sodium potassium ATP maturation and NMDA and AMPD receptors are much less than the adult. Third most common cause is for neonatal seizure much more because there is a delay in the development of GABAergic transmission in infant. That means GABAergic receptor are less in neonates than the adult, and they are also this GABAergic receptor is mainly having inhibitory effect in the brain. That means they are prevent from the seizure activity, but in infant, there are some GABAergic receptor having some excitatory effect. That means they are excitatory effect. That's why they are more prone having neonatal seizure. So that's why because there is a delay in the development of GABAergic transmission receptors. So that's why we are not treat in neonates convulsion with benzodiazepine as a first line drug, and we are giving with phenobarbital, and in case of more than 3 months we are giving benzodiazepine is a first line of drug. Why? Because the GABAergic receptor is just like an adult in an age group of more than 3 months. Now, what is the types of neonatal conversion? Neonatal conversion are divided into two types according to the EEG finding and clinical activity. So, according to the clinical activity, they are divided into different types of conversion. But according to the EEG activity, they are divided into two types. One is EEG electroclinical seizure. That means EEG having electrical activity of seizures and also associated with signs and symptoms of seizure. That means EEG is plus EEG positive for the seizure, and EEG finding is there, and also there is a clinical signs and symptoms of conversion. And other types is only EEG only positive seizure. That means the EEG finding having electrical activity of seizure, but there is no clinical signs of seizure. So always if a patient having convulsion in neonatal period, always do an EEG as early as possible. In between the seizure, during the seizure, you and if a patient having convulsion, during the convulsion you can do EEG. You can do EEG after completion of conversion, and it is better to do EEG as a videometric EEG for 24 hours, because we can see the electrical wave activity after the seizure, and we found that if there is a seizure wave formation, then the child may not having some clinical signs of seizure, but there is a electrical activity which shows the child may having some seizure. And that's why, so if a patient having some electrical activity of seizure, then we also treat the patient having neonatal convulsion without any clinical sign. So there is sometimes there is a seizure-like mimic activity we can occur in neonates, and we are confusing that the child may having some neonatal convulsion. So what are the seizure-like mimics? That is roving eye movement, nystigmatoid jerky movement, sucking movement, or other limb movement during sleep or in a drowsy state may be mistaken as a seizure activity, and we sometimes start anticonvulsant. How do we differentiate between convulsion, neonatal convulsion from this seizure-like activity? The movement will stop after gentle resistance, and there is no autonomic phenomena occurs. So autonomic phenomena means increase of heart rate, decrease of the blood pressure, increase of the respiratory rate. If a patient having convulsion with autonomic phenomena activity, then there is a convulsion is present. If there is a no autonomic activity is there, then there in this maybe child having some seizure like mimic activity, just like this. So always you have to differentiate between the seizure like activity from the neonatal conversion. And the most common cause for seizure like mimic activity is hypoxic HI or metabolic or with drug withdrawal. How EEG criteria is used to diagnose neonatal conversion. So EEG, always do EEG for neonatal conversion. Please be remembered. It is very important that always do EEG if a patient having neonatal conversion. But in case of febrile conversion, you may or may not do the EEG. It is not necessary to do EEG if a patient having febrile convulsion. But if a patient having neonatal convulsion or convulsion more than 5 years of age, it is necessary to do an EEG as early as possible. But in case of febrile convulsion, you have to do the EEG after 2 weeks of convulsion. Please be remember, this is an already MCQ. If a patient having febrile seizure, if you need to do an EEG, you can do the EEG after 2 weeks of seizure pre-episode. If a patient having neonatal convulsion, or if patient age is more than 5 years with convulsion, or if a patient having afebrile convulsion, then do EEG as early as possible. During the convulsion, in between the convulsion, and after the convulsion, you can do anytime, but EEG is necessary and you must have to do the EEG. So, what is the EEG criteria? Sudden change in the EEG. That means if you do an EEG in a normal patient, if there is a sudden change in the electrical activity of a EEG, that means if the clinical sign of conversion is not there, but there is a sudden change in the electrical activity of an EEG, that means the child having neonatal conversion. There is a repetitive waveform that evolve in the morphology, frequency, or the location. If this criteria, any one of the morphological change, waveform change, or frequency of the waveform is changed, or there is a location change of the waveform, then the child having neonatal conversion. The amplitude is more than 2 microvolt. This is an MCQ. That means more than 2 microvolt of amplitude have to be changed to diagnose having neonatal conversion. And the duration of this abnormal electrical activity is at least more than 10 seconds. So if there is a abnormal electrical wave activity is more than 10 seconds, then only the child having diagnosed as a neonatal convulsion. Clinical sign may or may not be present. That means clinical sign may not always present if a patient having neonatal convulsion. Why? Because the brain is immature. There is a no synchronized between the brain synapses with the muscle synapses. That's why some many time the electrical activity from the brain may not enter into the muscle properly. Therefore, there may be some the muscle may not have stimulated by the brain stimulation, and there is a no sign of convulsion or no sign of chronic jerk movement. But there is a electrical activity present in the brain, which is found in the EEG. Seizure can be divided into few types. That means unifocal. That means seizure waves are present in one single region. That means if we draw a brain, there is a seizure focus is present in one part of the brain only. Multifocal means seizure originated from all three independent foci with at least one in each hemisphere. That means if we divided the brain into four hemisphere, that is frontal, occipital, temporal, and parietal, then there is at least three lobe are in at least three lobes are infected by the electrical activity. Lateralized EEG finding means the seizure propagated within a single hemisphere. That means suppose one electrical activity is start from left side of the and this is right side left side parietal region. That means this propagated to left-sided parietal region or left-sided occipital or frontal region, but it cannot go into the right side. That means lateralized. Bilateral means both the hemisphere are involved and the electrical activity start in both the hemisphere. Migrating means the seizure moves sequentially from one hemisphere to other hemisphere. That means if there is a seizure activity, start from the left temporal region, that enter into the right sided frontal, temporal, or occipital or parietal region. That is migrating. Diffuse means asynchronized involvement of all brain region. That means the seizure focus is present throughout the brain in different amplitude and different time. So these are the EEG types of neonatal convulsion. Now come to the clinical classification of neonatal convulsion. Neonatal convulsion is divided into five types according to the clinical classification. One is tonic convulsion, one is clonic convulsion, one is myoclonic, one is spasm, one is subtle seizure. In between the clonic seizure, it is divided into focal. That means one part of the hemisphere is only involved. One is generalized. That means it is involved throughout the all the hemisphere on all the brain part of the brain is affected. Clonic is divided into two parts. One is focal. That means one hemisphere is involved. One is multifocal. That means one hemisphere is involved or multiple hemispheres are involved in one portion of the body. Myoclonic is divided into focal, multifocal, or generalized. Spasm. Now, what the most common type of neonatal convulsion is subtle seizure. So this is an MCQ. The most common type of neonatal seizure is clinical type of neonatal seizure is subtle seizure. Most common cause of neonatal seizure. What is the most common cause of neonatal seizure? That is birth asphyxia. What is the most common metabolic cause of neonatal seizure? That is hypoglycemia. What is the second most common cause of metabolic cause of neonatal seizure? That is hypocalcemia. These are our MCQs. The overall most common cause of neonatal seizure is birth asphyxia. Overall most common type of neonatal convulsion is subtle seizure. Overall most common type of metabolic cause of neonatal convulsion is hypoglycemia. Second most common is hypocalcemia. Most common cause of neonatal convulsion in diabetic mother is also birth asphyxia. Most common metabolic cause, that is also hypoglycemia. Neonatal convulsion with best prognosis according to the clinical classification is subtle seizure, having the best prognosis. The worst prognosis is myoclonus seizure. The microclonus seizure having the worst prognosis and the best prognosis is subtle seizure. The best prognosis according to the cause, the best prognosis of neonatal conversion according to the cause is late onset hypocalcemia. Late onset hypocalcemia has having the best prognosis. The worst prognosis is birth asphyxia and the meningitis. So meningitis with neonatal conversion having the worst prognosis. And the best prognosis according to the cause is late onset hypocalcemia. Now come to the etiology. If a patient is suffering from neonatal convulsion within 24 hours, then the first and foremost cause we are think about is birth asphyxia HI2. So birth asphyxia HI2 is the first and foremost cause of neonatal convulsion. After that, there is stroke, that means subarachnoid hemorrhage, germinal matrix intraventricular hemorrhage, or subdural hemorrhage, or there is a pyridoxine dependent convulsion, or if there is intracranial infection or sepsis, or hypoglycemia, hypocalcemia. These are the causes of neonatal convulsion age less than 24 hours. Age in between 24 hours to 3 days, the most common cause is intraventricular hemorrhage in premature baby. After that, subarachnoid hemorrhage, subdural hemorrhage, or meningitis. More than 72 hours to 1 week, the most common cause is infection, that is meningitis. After that, there is a benign neonatal idiopathic seizure. That is fifth day fits. It is an MCQ. Fifth day fits after 72 hours. The most common benign cause of neonatal conversion is benign neonatal idiopathic seizure. That means fifth day fits. Now, what are the investigation will you do if a patient having neonatal convulsion? So, first and foremost investigation we have to do if a patient, if a children, neonates having neonatal convulsion is blood sugar. We have to do see the blood sugar. So, if a patient having neonatal convulsion, always do an CBG, blood sugar testing. After that, we do taking the blood for calcium, magnesium, sodium, potassium. We have to do the urea creatinine and CSF study to rule out meningitis and the sepsis screening to rule out any sepsis. Serum bilirubin to rule out kernicterus and AVG to rule out some metabolic causes of neonatal conversion like galactosemia or uric acid defect. The first investigation of choice is blood CBG, and the most definite investigation of choice is AI integrated EEG or videometry EEG. This is an MCQ. So the definite investigation of choice is videometry EEG or AI amplitude integrated EEG. The AI EEG or videometric EEG is the investigation of choice, and the first investigation we have to do is blood sugar. Question asks that a child comes to you, a unit comes to you with having conversion. So what are the investigation will you do first? We will do first blood sugar testing. And what is the most definite investigation will you do for this patient? The answer is AI EEG or videometry EEG. Now treatment protocol for neonatal conversion. So first, if a patient comes to you having neonatal conversion, we first do an cannula and do the ABC. That means airway, secure the airway, breathing and circulation, and do an IV access and check the RBC. That means blood sugar. We always check the RBC first. If the blood sugar is less than 40 millimeter per dl, that means the child is suffering from hypoglycemia. As I say, hypoglycemia is the second most common cause of neonatal conversion. So we have to treat the patient with 2 mg per kg bolus of deep 10% dextrose. That means we have to give D10 at a rate of 2 ml per kg bolus and start GIR, glucose infusion rate. So this is the MCQ. That means if a patient having hypoglycemic conversion, the treatment of choice is giving bolus of 10% dextrose at a rate of 2 ml per kg. If the CBG, if the blood sugar is normal, then we check the calcium, as because the hypocalcemia is the second most common cause of hypocalcemia is the third most common cause of neonatal conversion. So we check the ionized calcium by taking the ABG. If the ionized calcium in ABG is less than 4.4 milligram per DL in term and preterm weight more than 1.5 kg, or if it is less than 4 milligram per DL in preterm less than 1.5 kg, we give calcium gluconate 10% at a rate of 2 ml per kg IV over 5 to 10 hours with a cardiac monitoring. So that means if a patient having hypocalcemia, the treatment of choice is giving 10% calcium gluconate at a rate of 2 ml per kg. If the seizure is subsided, that means the child having hypocalcemic seizure. If the calcium after giving calcium gluconate, the seizure is not subsided and the child having hypocalcemia, so we can give a second dose of calcium gluconate. If the seizure is not, if the seizure is persist after giving second dose of calcium gluconate and child is suffering from hypocalcemia, then we give magnesium sulfate 50% at a rate of 0.2 ml per kg. So this is the treatment protocol of hypocalcemic convulsion. Suppose in your hospital, the facility for doing calcium, ionized calcium is not available. Then first check the CBG. If CBG is normal, then give a bolus dose of calcium gluconate. Because you are thinking that the conversion may due to hypocalcemia. After that, if the seizure is not subsided, then you start giving the anticonvulsant drug. If there is a facility of ionized calcium if there is a facility of doing ionized calcium as early as possible, then do the ionized calcium. If there is ionized calcium is normal, then only give the phenobarbital. The dose of phenobarbital is 20 mg per kg. That means 20 mg per kg IV bolus given slowly over 20 minutes with mixed with 20 ml of NS. So after giving this phenobarbital for 20 minutes, if the seizure is not subsided, if the seizure is present, then we give another dose of phenobarbital at a rate of 10 mg per kg, and we can give up to 40 mg per kg. So that means we giving 20 mg of per kg IV bolus first dose. The seizure is not subsided. We give one more dose of phenobarbital at a rate of 10 mg per kg, half dose. If the seizure is not subsided, then we give second anticonvulsant, that is phenytoin. We give phenytoin or fosphenytoin at a rate of 20 mg per kg run over 10 minutes. So after 10 minutes, if the fever seizure is not subsided, then we start giving benzodiazepine, that is midazolam infusion at a rate of 0.5 to 1 microgram per kg per minute up to 80 microgram per kg per minute, and we consider the patient in mechanical ventilator intubation and we shift the patient to NICU. So first we have to give the phenobarbital first dose 20 mg per kg. The seizure is not subsided, then 10 mg per kg. The seizure is not subsided, then give again 10 mg per kg. So up to 40 mg per kg. That means two 10 mg per kg dose. If the seizure is not subsided, then we give phenytoin at a dose of 20 mg per kg over 10 minutes. If the seizure is not subsided, then we give midazolam infusion. After midazolam infusion, we increases the midazolam infusion from 1 microgram per kg per minute up to 80 microgram per kg per minute, but in every 5 minutes interval. If the seizure is not subsided, if the seizure is persist, then we can add pyridoxine as the IV dose. We can give folinic acid and we can give levetiracetam at a dose of 10 to 30 microgram per kg per day. If the seizure is persist, then we give the extremely, in case of extremely resistance seizure, we give lamotrigine or valproate at a dose of 20 mg per kg per dose. So this is the protocol of giving neonatal convulsion. Now after treating the neonatal convulsion when the convulsion is subsided. Then the question is how many days we can give the anticonvulsant to the patient. So if a patient having neonatal convulsion, so the duration of anticonvulsant therapy is determined by three factors. That is, the first and foremost factor is neurological examination. If the neurological examination is normal, then we only stop the anticonvulsant drug. So if the neurological examination is normal, then we always stop the anticonvulsant. Now, the cause of neonatal seizure. If there is a subarachnoid hemorrhage is there, the then we the anticonvulsant. If the neurological examination is also normal, then we can continue the anticonvulsant as because there is a predisposing factor present in the brain, just like hematoma. Till the hematoma is not subsided, we can continue the anticonvulsant. And in electroencephalogram, that means EEG finding. If the child is neurologically normal and EEG is abnormal, we can stop the anticonvulsant. But if the neurological examination is abnormal and EEG normal, then we can also stop the anticonvulsant. But if the neurological examination is abnormal and the EEG also abnormal, then we can continue the anticonvulsant. So that means the neurological examination is the first and the most determinant part for the determination of continuation of the duration of anticonvulsant drug. So this is also an MCQ. So what is the most important factor which determine the duration of anticonvulsant therapy of a neonatal seizure? That means how many days we can continue the anticonvulsant drug. So neurological examination should be done before discharge of this patient. If the neurological examination becomes normal, then discontinue all the anticonvulsant. And we have to plan before discharge. We have to omit all the anticonvulsant except phenobarbital. If neurological examination is persistently abnormal, then consider the etiology and EEG. So consideration of the EEG and the etiological cause of neonatal convulsion is only considered when the neurological examination is abnormal, and we only continue only phenobarbital as anticonvulsant. So if suppose a patient is having convulsion and we giving phenobarbital, the convulsion is not subsided. The convulsion is subsided after giving phenytoin. So, but we only discharge the patient with phenobarbital. We have to taper and stop the phenytoin before discharge. So, only our plan is to give only phenobarbital if there is a neurological abnormal, and we have to omit all the anticonvulsant, and we recheck the patient after 1 month. So, after 1 month of discharge, we again do the neurological examination, and if it become normal, then we discontinue the phenobarbital after 2 weeks in a tapering dose. If the neurological examination is abnormal, then only we do an EEG testing. So if there is a no seizure activity in EEG, so if the neurological examination is abnormal but EEG is normal, then we can discontinue the phenobarbital. So this is very confusing. That's why we are giving a flow chart to decrease the confusion. So after treatment of the neonatal convulsion, the neonatal convulsion period is over and the child convulsion is subsided, and the patient is now ready for the discharge. So before discharge, we wean all the anticonvulsant except phenobarbital. So once the seizure is controlled, and before discharge, we do the neurological examination. It is very important. We only do the neurological examination. So after neurological examination, if the neurological examination is normal, then you stop the phenobarbital. If there is a neurologically abnormal, that neurological clinical test, when we do the neurological examination, the neurological examination is abnormal, then we continue the phenobarbital for 1 month and perform the neurological examination after 1 month. of discharge. So we discharge the patient with only phenobarbital. If the patient is after 1 month, then patient, when you do the neurological examination, the neurological examination is normal. Then what we will do? We stop the phenobarbital with the tapering dose. So if the neurological examination is normal, so we stop the phenobarbital. If neurological the patient is abnormal, then we do an EEG. So EEG is only done after if 1 month if there is a in neurological the child is abnormal. But in my previous slide I have said that we have to do the EEG as early as possible during the convulsion, after the convulsion. Then what is the role of that EEG? That EEG is only to diagnose the convulsion. That means the child is having the child is having only conversion. We have to diagnose this. So this EEG is only need for the diagnosis of convulsion, but this is not for the long-term treatment protocol. This EEG is only for the diagnosis part, but for the long-term treatment, we have to do the neurological examination. If the neurological examination is abnormal, then we again do an EEG. So after performing the EEG, if the EEG is normal but the child neurologically is abnormal, then we can stop the phenobarbital by tapering the EEG. And the cause of also the cause of the seizure is not reversible. That means the cause, suppose the patient having convulsion due to intracranial hemorrhage. So if there is a blood hematoma is there, then we should not stop the phenobarbital. But if the patient is having convulsion due to meningitis or infection, then we can stop the phenobarbital because the antibiotic has the role to decrease the meningitis. And if the patient having convulsion due to hypoglycemia or hypocalcemia, then we can stop the phenobarbital. That means the cause have to be reversible and the EG is normal, then we stop the phenobarbital instead of neurologically abnormal. But if the patient is neurologically abnormal and the EEG is abnormal also, then we continue the phenobarbital for 3 months and again we perform a neurological examination. So neurological examination is the first and foremost determination factor. After 3 months, if the neurological examination is abnormal or there is a delay in the development of the child, then we continue the treatment as because the EEG is abnormal. If the EEG is normal and the neurological is abnormal, neurological examination is normal, we can stop the phenobarbital. But if the EEG is abnormal and the neurologically the child is abnormal, then we continue the treatment till the child is become neurologically normal or there is a no delay in the development of the child. So these are the treatment protocol for the continuation or the neonatal conversion. So this is for today. So the MCQs are what is the most important determinant factor for the continuation of the long-term treatment of anticonvulsant if a patient having neonatal seizure? The answer is neurological examination is the first and foremost determinant factor for the duration. EEG is done to diagnose the neonatal convulsion and to rule out the convulsion mimic episode from the convulsion. So EEG is only having role for diagnosis of neonatal convulsion. That means that child is surely having neonatal convulsion without any clinical signs or symptoms. The child, if there is electrical activity of present in the EEG, that means the child having neonatal convulsion. So to diagnose a neonatal convulsion, the investigation of choice is EEG. To diagnose the long-term treatment protocol, the determinant factor, most important determinant factor is the neurological examination. And the drug of choice for neonatal convulsion is phenobarbital. The drug of choice for hypoglycemic neonatal convulsion is dextrose 10%. The drug of choice for hypocalcemic neonatal conversion is calcium gluconate 10%. The drug of choice for subtle seizure is phenobarbital. The most common cause of neonatal convulsion is the most common type of neonatal convulsion is subtle seizure. The most common cause of neonatal convulsion is birth asphyxia. The most common metabolic cause of neonatal convulsion is hypoglycemia. The most common cause of neonatal convulsion, which having the worst type of prognosis is child having meningitis with neonatal convulsion. The most common type of neonatal convulsion having the worst prognosis is myoclonic convulsion with myoclonic multifocal convulsion. So this is for today. Thank you.